Hey guys, it's Mike, and I am back with Tom, and we've got another billing and coding update for you all. And as we alluded to last week, we have a critical care case example today that I think will be probably a pretty good one.
I think we'll do a couple of cases over the next 2 weeks, but we'll see. Anyway, so let's start with this case. And these are all from a lecture that I give to the residents. So
and these are all real life examples too. There's nothing in here that's made up. We've all reviewed these cases at one time or another.
This is from a real chart, and this is the ED course of medical decision making on a patient. So it says, upon arrival, poor mental status, some respiratory insufficiency, BiPAP was ordered, Narcan was given, patient woke up a little bit, they did a head CT, they were going to observe the ED for a brief period of time, and then their mental status deteriorated again. They got an ABG, it was worse. So they consulted ICU medicine and they repeated Narcan. So this is a lot of things happen with this particular patient in the ER. There's altered mental status.
Certainly sounds like somebody who's appropriate for critical care.
Sure, respiratory insufficiency. So what did they document? So here's the critical care procedure note, and they talk about the system at risk for life-threatening failure, CNS and respiratory, associated problems.
Sounds appropriate.
Hypercarbia and metabolic changes. I agree with that.
Appropriate.
Procedure, services, chest X-ray interpretation, time, 15 minutes. So is this a medical student reading this chest X-ray?
I don't know.
Like a college student?
Maybe it was the physician's family watching him read the chest X-ray, and it felt like 15 minutes because it was so long.
We could do three or four critical care coding pearls in 15 minutes.
Well, you like to talk a lot, so I don't think we could actually do 4.
We could do 3 for sure.
Maybe 2.
Okay, so you're going to look at a chest X-ray.
We might finish this in 15 minutes.
1 minute, 2 minutes tops to interpret a chest X-ray, unless you document that you had 3 or 4 previous X-rays that you were comparing them to. You're toggling back and forth. You're measuring the size of an effusion. Who knows?
Right.
But if you're documenting more than 1 or 2 minutes to interpret a chest X-ray, you better explain why.
Right.
But then under management, bedside management, test review, record review, case discussion, case documentation, all looked good, and there was 30 minutes there.
Which is appropriate. That's all you need to document critical care is 30 minutes. You could have put 0 under chest X-ray interpretation, and you would have still been okay.
So 30 minutes is a minimal. So we like the time in the management. We do not like that problem with the chest X-ray. So they use way too much time to put under chest X-ray interpretation. Makes no sense.
What was the other problem with this documentation here?
Well, I don't know, Mike. Why don't you tell us what the other problem is?
You have to have timed assessments and timed progress notes.
Let's just put it this way. We're not going to say have to. We like them. They make it much easier to show the amount of time that you spent. However, even if you don't have exact times or time progress notes, there's enough here to justify it's clear that you spent more than 30 minutes. However, to make it even more clear, a time progress note, dot now is your friend.
And you can, it's very easy to go back after the fact and look at those. You just have to look at when you ordered stuff.
Right.
Because I guarantee as this patient went along, they could have figured out about what time the patient got worse by looking at when they ordered the ABG.
Exactly. So anyway, dot now is your friend. So use it. And so understand critical care is a procedure. You can find the critical care note under the procedure tab in Note Writer. So a lot of times we have critical care patients, so we do other procedures. So we do EKGs, we might do a bedside ultrasound, we might intubate them, do a central line, draw blood, put an IV in, put a chest tube in, CPR, etc. What about all those procedures, what do they all have in common?
So we bill for all those procedures separately.
Exactly.
And when you add up the amount we get from critical care and billing from those procedures separately, it's more than if we just billed for critical care.
No question about it.
So it makes sense to bill them separately, and if we bill them separately, we can't include them in critical care time.
So let's say you have a patient that you spent 45 minutes doing critical care, and 15 minutes of that time was spent putting a tube and a central line in. You have 2 choices. You can include endotracheal intubation in the central line in your critical care time and bill for 45 minutes of critical care, or you can bill for 30 minutes of critical care and then take the 15 minutes out that you spent doing the endotracheal intubation in the central line, document them as separate procedures, and you can bill for all 3.
Right.
That's perfectly appropriate and is the more desirable approach.
Right.
There's a couple of caveats. If a patient dies in the ER, you can still bill critical care, but you can only do critical care while a patient's alive. So if a patient hits the door at 7 o'clock and at 7:25 they're pronounced, even though you may spend a significant amount of time after 7:25 documenting the chart, calling the medical examiner or their
Talking to the
physician,
family.
etc., you can't bill critical care because critical care is only applicable while the patient's alive. So, just a few caveats. So we like you to exclude your procedures from the critical care documentation. And there's in fact a part of the note that says procedures that were included and procedures that were excluded.
Right.
So now, here's the thing. If you intubated a patient and you only spent 30 minutes on critical care, including the intubation, just include the intubation in the critical care time and bill for the 30 minutes. But you don't make it up. If you spend 30 minutes with the patient and part of that time was spent intubating the patient, you can't say 30 minutes of critical care time plus the time to intubate because that's more than 30 minutes and you only spend 30 minutes.
Although I would argue that anytime you intubate somebody, you've probably spent way more than 30 minutes with them. Total.
Probably, yeah. But suppose the patient dies.
Well, hopefully that doesn't happen. But.
Exactly. That's why you intubated them.
So back to the case.
All right, so there's some documentation pitfalls with critical care. You either don't clearly document your time, in which case the coders will come back to you and say, please document how much time you spent on critical care, or your critical care time is inappropriate,
Right.
or, and it's not on the slide, and I apologize for that. I'll have to fix the slide for my next lecture, or you included procedures in your critical care time that you probably should have excluded and billed separately.
Right.
I hope that makes sense. If it doesn't, please query me separately or we'll do another coding pro
Right.
on it, unless you're sick of critical care and procedures.
But I hope not, because we've got one more case for next week.
Absolutely.
So, all right, till then.